As you know, they're hosted by the Gastro Foundation in association with Project ECHO of the University of New Mexico. These sessions are held weekly on a Wednesday. The HCC meeting that we have today is approximately every 5 to 6 weeks. And then during the presentation, during the whole presentation, the chat will be open for any questions, so I'll keep an eye on that. Otherwise, when it comes to discussion time, feel free to unmute and just ask your questions. So it's really a pleasure for me to introduce this session. We, at these meetings, mostly speak about the surgical or the interventional treatment of HCC. And for this session today, we're going to concentrate on TACE, starting off with a talk on which patients, choosing the optimal candidates for TACE, and that's by Dr. Schyff van der Schyff, a fellow in medical gastroenterology at University of Cape Town. Dr. Sanju Sobnach in Johannesburg will talk to us about bench to bedside approaches for TACE. Then there will be 2 case presentations by Brian Misio and Mark Bhana, also from the University of Cape Town. And finally, Bhana will talk to us about the complications of TACE and post-procedural follow-up. Right. I think in terms of the treatment spectrum of the way that HCC presents in Africa at the moment, TACE is probably one of the most important treatment modalities. And I think the need for TACE in Africa at this point probably much higher than the need for any curative treatment due to the late presentation. So Nassif, if you're ready, we can start.
Yeah, Prof, I'm ready. Good afternoon, everybody. Let's start my presentation. Afternoon, Prof, can you hear me?
We hear you well.
All right, thank you. Thanks, Prof. So I've been asked to speak about TACE, and I'll be reviewing this important article, this review article that was published recently. It's focused on the current strategies to identify patients that will benefit from TACE treatment and some future directions. So just as by way of introduction, trans-arterial chemoembolization called TACE, it's a standard treatment for the intermediate stage in patients with HCC as per the Barcelona criteria. It has a median survival of about 2.5 years, but with the correct patient selection, we can increase that survival for this cohort of patients up to 4 years with TACE. It's important to note that there's actually a dearth of data to sort of guide us, and most of the recommendation is mainly on 2 trials. And from both those trials, there were a highly selected patient cohorts. But important to note is that within this intermediate stage, there's quite a sort of a heterogeneous group where there's significant difference in tumor burden as well as the liver functions of patients. So one patient in the intermediate stage may not be the same as another patient. And therefore, not all patients may benefit equally from TACE. And therefore, it's important to select the right patient. So the critical points before and during TACE treatment will be firstly to identify what is your ideal candidate to start TACE. Then number 2, to try to support decision-making during the course of them receiving treatment. Then also in providing guidance on when to stop. So we'd ideally, as I said, we'd identify what is the key features, we'd start TACE. After that session, we would evaluate the response and thereby sort of deciding if the patient is candidate for further TACE sessions. So just starting in terms of what are the ideal candidates. So when we do cross-sectional imaging, there are important features on our cross-sectional imaging that may help us to decide. And the first one would be, number 1 is the tumor size and the number of lesions. So typically a large tumor, and the number that's been that's been found to be significant is tumor size more than 5 centimeters. So we know that if there's a large tumor, there's a less of a response to TACE, but also there's a higher chance of complications, most notably the post-embolization syndrome. Patients, as per the imaging, there may be features that indicates very aggressive tumor biology. And for that, the vascular nature of the tumor is important. So we know that patients that have hypervascular tumors, they are more responsive to TACE, they're easier to identify during treatment, and also they have a favorable outcome. Also, the arterial anatomy is important. So when there are few tumor-feeding vessels and there's favorable anatomy, in this cohort of patients, may allow for so-called, very selective embolization of particular segments, or so-called superselective embolization. And because in this category of patients, we're aiming to maximize tumor necrosis, but also protecting the surrounding healthy liver. Also, in terms of the tumor aggressiveness, that is affected by the growth pattern as per the imaging. So if we see patients that have infiltrative tumor growth, they have an impaired response to TACE and a decreased survival. On the contrary, patients that tend to have a nodular tumor growth with very clearly defined boundaries, they have an improved response. Then there are other features on our imaging that may help us to identify patients that are so-called adverse prognostic features. Presence of ascites, presence of hepatomegaly, presence of pulmonary hypertension as affected by splenomegaly. Then from a laboratory point of view, looking at the liver functions, and alpha-fetoprotein has been identified as two of the key features. Now, the Child-Pugh score has become the standard, as to how we stratify patients with cirrhosis. However, in the context of HCC, there are two major restrictions that this article has highlighted. Number one is that when patients decompensate on the path to cirrhosis, that's not affected in the Child-Pugh score. But also, the Child-Pugh score has a few objective parameters, such as encephalopathy, that is subjective, and that may hamper its validity. So from the literature, there's a few additional tools that has come up, and probably one of the most notable ones is what they call the albumin-bilirubin score, so-called the ALBI score. And this score estimates the liver reserve, it's highly predictive. We know that albumin has a good marker of liver function, has strong prognostic value. We also know that a raised bilirubin is associated with post-procedural decompensation. So this ALBI score has been validated in all the stages as per the Barcelona criteria. In terms of the alpha-fetoprotein, which we use in a day-to-day practice in managing these patients, just to remember that alpha-fetoprotein plays a role in tumor angiogenesis. It affects tumor cell proliferation and tissue growth, and it is an independent predictor of survival in HCC. And important that, the values before and after TACE treatment is related to the median survival. So even though the optimal cutoffs hasn't been clearly identified, a number of 500 post-treatment has been shown to be a good response. So just to summarize, when you evaluate patients for TACE, there may be patient factors relating to a lower ALBI score, preserved liver functions, good performance status, no comorbidities, no decompensation. In terms of the treatment factors, it may be a very super selective approach. If we can perhaps only target one or two segments, it is a favorable anatomy. And there's tumor factors such as as I said, the hypervascularity, the size of the tumor, a single lesion, distinct boundaries, and intact capsule on the alpha-fetoprotein level. In terms of what's the best technique, whether you use conventional TACE or whether you use TACE with your diluting beads, the data suggests that there's no significant difference in terms of tumor response and survival. However, your diluting beads is associated with fewer side effects. Now, once we've given TACE, how often should it be repeated? It's important to note that after every session of TACE, this patient should be carefully reevaluated, especially in the context of a multidisciplinary team. But one session of TACE may not be enough to cause tumor a reduction in tumor size. The criteria that has been used to assess has been initially the RECIST criteria, which is based upon the maximum tumor diameter, but that is thought to have underestimated tumor response. So a later version of this RECIST criteria, with the understanding that HCC is a very hypervascular tumor, we're now able to measure the longest diameter of contrast enhancing tissue. So the modified RECIST criteria essentially categorize patients into 4 categories: whether or not there's a complete response, where post-procedure there's no intratumoral enhancement, a partial response, at least 30% improvement, stable disease, no real change, or progressive disease on TACE. Some patients may improve and progressively find more than 20%. Why is it, right? And then in terms of you've given a TACE treatment, there are certain categories of patients that one shouldn't continue with, and those patients could be candidate for systemic therapy. And when we reevaluate patients using clinical criteria, performance status, imaging that I spoke about, and the liver function alpha-fetoprotein, but patients that are either initially unresponsive or they pretty much they deteriorate. What categories are those? Those are patients with a high tumor burden, they have multifocality. If there's an early recurrence or incomplete necrosis after TACE, Importantly, if there's vascular involvement, if once patients had TACE, there's a massive progression of extrahepatic spread, there's impaired liver function, worse in performance status, but also if the TACE side effects are just too bad. So this flow diagram just summarizes what I have just said in terms of the pathways, whether it's a complete response, whether it's a residual response, or patients that are unresponsive. In the interest of time, I'm going to leave the slide. All right. Thank you very much, Prof.
There we go. Thank you very much, Nassif, for a very compact but very nice talk. And a lot of the questions I think that we are basically facing every day when choosing these patients for this treatment and deciding when we have to stop and when we can continue. Are there any questions from anybody in the audience? I've got one or two, but I'm just want to check if there's anybody else. Right. So Nassif, one of the discussion points that often come up in the MDTs when you have got access to all the different treatment modalities is when you have a patient that falls in that category, and we're not talking about somebody that's going to be TACE as a bridge to transplant or a bridge to surgery, but where that will be one of the definitive treatments for a patient being treated palliatively. When would you choose systemic therapy and when would you choose a TACE? And the second thing is, do you think there's any place for doing these at the same time?
Prof, in terms of the systemic therapy, I think a lot depends upon the clinical status of the patient. And one of the factors that have been identified as adversely prognostic is the liver function. So even though on cross-sectional imaging, they would have very favorable tumor biology and imaging characteristics, but clinically, the patient has impaired liver function, if they have a bad performance status. If it's patients that had TACE before, that, as I said, if they've had bad side effects previously, but especially the liver functions and the clinical scenarios are two of the features from this paper that I've reviewed that has highlighted. I'm not sure, Prof, practically, are there any other criteria that I may not have mentioned?
Yeah, I think there are more questions than answers in this. Just one comment is that we in South Africa in the public service do not have access to any systemic therapies. There was, when sorafenib started, some patients that were on it due to some compassionate supply of the drug, but that was stopped. So we don't have the luxury of offering patients systemic therapy. And you have mentioned that your advantage in terms of survival of a patient with TACE can be up to 2.5 months, and if you're very selective, up to 4 years. But in the absence of systemic therapies, we've actually extended the criteria for performing TACE, because if we can extend survival in these patients, or an advantage in survival to up to 10 months, by extended TACE criteria, given that there may be more side effects and hopefully not any mortalities, that we can equal what you can achieve by systemic therapy. So we've actually been going the other way as well. Instead of being super selective and getting 4-year survivals, if we can get a 10-month survival advantage, we definitely beat sorafenib and probably lenvatinib as well. Any other questions or comments?
Prof, I'm just sharing this last slide that I didn't present, but this Optimus trial has been running since 2014. And it's a prospective observational trial where patients that didn't do well on TACE or they didn't respond to TACE, what has been the impact of having sorafenib? The trial is still ongoing. I'm not sure if it's been published yet, but there's a very dearth of data to answer that question. There's other drug that I've listed here. It's pretty much based on retrospective data and is not widely available.
No, like I said, we don't have it available at all. Karan Gandhi has got a question.
Hi, thanks, Prof. Good afternoon. Thanks for the talk, Nassif. I think very, very nice and concise summary. I wanted to know, I think, extending from what Prof. Jonas has just asked, because TACE is where we can probably make the biggest impact in sub-Saharan Africa in terms of our treatment, where we have maybe cardiology and cath lab services, and then we can use it. What are your thoughts on TACE in the presence of metastatic disease? Of course, like very selectively, but for example, you have a patient with a huge tumor burden in the liver and maybe has one or two tiny lung metastases, and you know that the primary is likely to kill this patient before the metastatic disease is. Would you think that it would be appropriate for us to maybe extend even further and offer these patients TACE? Do you think it's somewhere where we can actually look into, or do you think it's something that we should just label as an exercise in futility and stick to only local regional disease?
Yeah, I think that's why we need the Optimus trial data to help and guide us. But I think it's as this talk highlighted, it's about choosing the right patient. So even though there may be patients with very advanced disease, but if they have clinically, they're asymptomatic, they have good performance status, the alpha feta protein is not that high, it's under 500. I think that's a category of patients that one should consider. But I think I'd like to probably refer the question to Prof. Jonas or to Mark in terms of what has been their practical experience, because this category of patients represents probably the majority of patients that we tend to see.
Yeah, I think I'm going to defer that question to the next speaker. Sanju Sobnach, I think, is on. Sanju, I've already introduced you. We know that, and in your talk as well, Nassif, you spoke about size and number, and we know that there are a lot of other factors playing in at the moment, like tumor biology, etc., that I think is going to play a bigger role in the future in choosing these patients. Okay, Sanju.
Can you all see my screen?
Yeah, we see it. Thanks.
Okay. So we've spent the last fortunate to unfortunate 2.5 years, probably years we're never going to get back, as some people say, looking at what HCC does in sub-Saharan Africa. So this is our talk about the bench to bedside approaches for TACE in HCC. And we call this the Cape Town approach based on the latest findings that we have. So we show this slide all the time because for us, this work is really meaningful. I mean, it took us a good 18 months to generate this data to show that there's limited data throughout the 44 sub-Saharan African countries on this map. We know again that the majority of these patients are male. They're young and 47 years of mean age. And hepatitis B is a major problem on our subcontinent. Also to note that in the data we looked at, about 1/3 of the patients have non-cirrhotic HCC, which is a relatively rare entity in high-income nations. Now, let's just briefly look again at what high-income nations see. Well, they see predominantly cirrhotic disease, people who are 65 years of age. MAFLD, or what is now MASLD, is probably the main etiology. And the aim there to treat the patients is to get a survival of 70% at 5 years. In our region, it's 40 to up to 80% of the cohorts are non-cirrhotic HCC. Half of them are HBV related. The responses to therapy are really poor. So if you look at the sorafenib data, it's 106 days based on the Ethiopian data that's out there. In our cohort of 679 patients, it's 100 days. So it's pretty much equivalent. But I just want to remind people the data will come out very soon. But in our cohort, out of the 50 patients, about 50 or so patients who received sorafenib, we had to stop the sorafenib in about 1/3 of these patients because of terrible side effects. So again, it brings a question of tumor biology. And for many of us, tumor biology is not assessed in its true sense. We look at surrogates of tumor biology, which is response to therapy that is assessed by various things. So we look at patients clinically, we look at their size of their lesions or whether they've progressed on a CT scan. We use the well-known alpha fetoprotein. But we've brought this to many people's attentions many times, is that the alpha fetoprotein in our cohort is only elevated in about half of the patients. So half of all our patients with HCC actually have normal alpha fetoprotein levels. So we've had a set protocol for the past 2 years at CRISCare. So this is basically how we treat all our patients with HCC. We've had a very good system. Our patients are generally quite compliant, and we work them up quite extensively. And again, parallel to that treatment algorithm, there is a research algorithm in the unit And all patients out of this, I mean, we've enrolled about close to 200 patients over the last 2 years. We've had 2 patients who didn't consent and 1 patient who was too encephalopathic to consent. So the rest of the patients have been enrolled in the study. If they've had a liver resection, they've had tissue that's been biobanked. And all the patients have metabolomics done. A segment of the patients have some genomics and proteomics done. Our spatial transcriptomics study is well underway, and we've isolated exosomes already to examine the biology of this disease. So if you look at how many we've recruited so far, 200 from us, 20 from Namibia, and Zimbabwe at the time of the IHBB Congress had potentially recruited their first patient. So if we look at what we have in our database so long, so it's again what I've mentioned. We have patients who are quite young. We have a control group where we took blood from very healthy people. These are generally staff members of the hospital. You can see the HCC patients are in the 48 range. 63% of them are males. Again, cirrhosis and non-cirrhosis, almost a half and half split. Hepatitis B, 3/4 of the cohort. We have a 20% prevalence rate for HIV, and hepatitis C is only 2 patients, about 3% of the cohort. Now, we did metabolomics on these patients. Initially, the plan was to compare the cirrhotic and the non-cirrhotic patients. And we showed very early on with this work that non-cirrhotic HCC is actually biologically a different disease. Patients produce a lot of GLIC-B, they produce a lot of lactate, they have increased phenylalanine levels, which are all in keeping with very metabolically active tumors. We then went to show that patients who had metabolomic profiles very similar to the controls had longer survival, were having less weight loss, had reduced incidence of metastases, drank less, had lower levels of CA 19.9, which in our view is a good marker for HCC in sub-Saharan Africa. Also had high levels of albumin and sodium. Now, we went on to conclude that these non-cirrhotic HCCs have high levels of inflammatory markers, and they're obviously a different disease. At the same time, what we did is we used these markers to see whether we would be predicting survival in these groups. And what we found is that the patients that produce 2-hydroxybutyrate, which I'm going to call 2-HB from now, if you had high levels of 2-HB, your p-value was actually close to 0. You were most likely to die. We also went on to find out that high levels of creatinine, not creatinine, were also associated with increased mortality. The real question is now you have all this wonderful data. Can you apply it to treatment plans for your patients in the clinic? And so that's what we went along and did. So we took all the patients who got TACE. We went along to show that actually 2-HB, 2-hydroxybutyrate, is a byproduct of glutathione, which is mainly found in the liver. And we went on to postulate that elevated glutathione-related enzymes are observed in a number of tumors. You can see that with HCC, with pancreatic cancer. We know also that adaptive measures to oxidative stress lead to tumor resistance, and resistance thus to chemotherapy. We know doxorubicin, good old doxorubicin's action is by free radical generation, which causes DNA damage within the tumors. And then we also examined the BCLC-C and D patients who received TACE with doxorubicin at our center. I must say, if you follow the Barcelona criteria, that is frowned upon. These patients should actually be given mainly best supportive care. So we did 3 things. We evaluated some of their outcomes. We looked at the plasma metabolomic profiling of patients. And we then investigated the metabolites that are related to glutathione metabolism. So we had 675 patients at the time of this study. Of those, we had an 85% follow-up rate. We collected the clinical data. We then had this interesting lot of 58 HCC patients. We matched about 44 controls, and we did NMR analyses on there. So this is in the whole cohort of patients. So this is looking at these hazards ratios and what favors mortality in patients with TACE, sorafenib, and best supportive care. And I think the answer is here. If you have lung mets with HCC, you shouldn't actually be getting TACE based on our data. If you have advanced BCLC, that also predisposes to mortality. And then we had some interesting findings: high white cell count, a low platelet count, increased AST, increased ALP, and increased gamma GT. And in the sorafenib group, those who had ischemic heart disease and high ASTs didn't do so much. And then the best supportive care, that was obviously quite obvious what predisposed these patients to a high mortality. So we then measured plasma hydroxybutyrate, and we used that to predict overall survival and treatment responses to TACE in our cohort of patients. So again, if you have no lung mets or a gamma GT of more than 800, you can see the survival is in best supportive care is obviously the lowest, followed by sorafenib, but TACE again wins. Now, if you have lung metastases or a gamma GT of more than 800, then you pretty much die immediately. If you look at this graph, you can see that the survival is actually extremely low in these patients. So really, your policy should be that if patients have lung mets, particularly in an African cohort, where your gamma GT is more than 800, that's a surrogate marker of the amount of glutathione left in your liver. You should not be offering these patients TACE. We then looked at whether 2-HB levels affect outcome, and they do in all two cases. So if you look at the best supportive care group, if you have high levels of 2-HB, your mortality is extremely high, and that is the same for TACE. We then went along and defined short survival as less than 100 days and long survival as more than 100 days, and we went to find an optimal cutoff for a gamma GT, and that was again at 800. As we determined in this study. So some of the discussion points: so patients with lung mets or high gamma GT have shorter overall survival when they're given TACE. We were initially quite perplexed by it, but then we looked at some assays in the lab, and we showed that 2-HB is actually a byproduct of glutathione synthesis that happens in the liver, and essentially a marker of reserve function within the liver with HCC. Also interesting to note, I'm not going to give more than this away at this stage, is that 44% of the patients with high 2-HB actually have HIV Hep B co-infection versus 12% of the patients with low values. So we think that the patients with HIV and Hep B have poorer outcomes, and that might be related to their metabolomic profile. I mean, our manuscript is ready, as I spoke to Professor Jonas today, so that will be coming up very soon and showing why these patients actually die faster. So patients with BCLC-C and D benefit from TACE, provided the gamma GT is not more than 800. Again, that's a surrogate marker of glutathione reserve in the liver, and that they have no lung metastases. 2-HB and a gamma GT level could potentially guide choice of treatment in these patients. So TACE versus best supportive care. We think this is really important because TACE itself, as will be mentioned in the next talk, is not without its risks. It is invasive and there are potential complications. So we are working on this now. So our premise is that what if we could see on the scan already whether these patients have high hydroxybutyrate levels, and we can already mention whether they need, we can already determine from the scan itself whether they would be candidates for TACE or not. So the one way to do this is to integrate the data. We're busy doing that at the moment. Data's gone over to India for AI integration. So we hope over the next 2 years, what will happen is you just look at the scan and you place your AI probe over there, and you will know already whether this is a high HB, 2-HB tumor or not. So that can immediately determine whether this would be a candidate for TACE or not. I'm going to finish by saying quite happily that our program about 6 weeks ago has established a world first. So this is how we assess true biology in HCC. So about 6 weeks ago at Curtis Care Hospital, we used a hive to do single-cell RNA sequencing in a patient that was eventually TACEd. This is our bench. So this bench has now been halved in size over the last 3 months to accommodate it in a bag, so more people can do it in Africa. We use a fine needle, and this is a non-cirrhotic tumor. We aspirate the cells. This is what the percolate initially looks like. It's a bit blood-stained. Then we use the red cell depletion kit, and we take away all these red cells to get a clearer percolate, and that's loaded onto this hive. We pop the blue Tubing off, you load the hive, and then the hive is locked and ready for sequencing. So we have retrieved about 30,000 cells per tumors. As of Monday, we've recruited 5 patients, which is 150,000 HCC cells, which will all be sequenced individually. And we should be having some data over the next 6 months to really see what is going on. So in conclusion, bench to bedside approaches are realistic in sub-Saharan Africa. We cannot have voices from overseas telling us we cannot be doing this or it's useless for our patients. It really helps you to carefully select patients with advanced disease, particularly when you're planning invasive therapies for them. It's important to generate more true biological data for our patients in sub-Saharan Africa rather than relying purely on surrogates. And it's important, I keep on saying that, I even said that at our talk at the IHBBA, you must treat biology and not mass disease. Don't get thrown away by looking at the size of a tumor when the tumor itself is quite chemosensitive or sensitive to TACE based on their true biological data. So I'm going to finish with this slide, and I'm open to having any questions or discussions thereof.
Thank you very much, Sanju, for a really very nice talk. And I think, Nassif, it answers your question about the question that Karan had about metastatic disease. Before I start with questions, any questions from the audience or comments? Just 2 questions, Sanju. The first thing is you spoke about lung metastases, that we shouldn't do TACE in patients with lung metastases. What about other metastases?
So I think Mohammed has looked at some of the data. With our impression in the beginning is that we felt that they would behave like Mets from colorectal cancer. That was our initial feeling. And we've shown that that wasn't the case. Sometimes the feeling is not good enough for patient management. I think with regards to most other metastases, one must be cognizant of some of the potential treatments out there. Certainly for abdominal, peritoneal, or extrahepatic Mets within the peritoneal cavity, the biologics would be a favorable modality of care. In our setup, when there have been bone Mets and they've been symptomatic, we have used palliative radiotherapy, and that's given our patients a bit of relief. The other thing I want to say is that one mustn't forget the patients who've had a liver resection or transplant and then have this isolated Met in their lungs 4 or 5 years after their definitive treatment. I think these patients must be treated differently. At the IHBBA, there was a huge discussion about it. And Halazoon from New York actually showed that they go and burn those lesions. They either do radiofrequency ablation or they do a formal lobectomy to clear those patients. So I think there's a place for more invasive therapies. I just want to remind people that we are looking at BCLC and D, whatever that means in an African setting. So patients with super advanced disease. But I really think people should make very special cases for patients with early liver disease in an isolated lesion, whether it's extrahepatic or pulmonary.
Thanks, Sanju. Just the last question, the gamma GT. Why do these patients do bad? Is it a surrogate marker for biliary obstruction?
Yeah, no. So I initially thought that's what it was. I thought it was just a congested liver. When we look back at the assays in the lab, it looks like the gamma GT is a surrogate of glutathione. And you cannot actually metabolize doxorubicin in tumors if you don't have a glutathione reserve. And that's the reason for it. It's a very simple one. I'm surprised it took us 20 years to figure this out now. After 20 years, we figured this out in the lab, but that's the reason. I remember Professor Ramos once saying that he doesn't understand why he has patients who've been TACE so many times and are now 5 years out and still alive with TACE. And the reason is probably these livers have very good glutathione levels. And these tumors remain highly sensitive to very cheap chemotherapy. Doxorubicin is about 800 rands a pop. So, yeah.
Okay. Thank you very much, Sanju. If no questions, I think we can go on to the 2 case reports. Mark and Brian, I think the first one can start.
I'm happy to start. I'm just going to share my screen. Can you see that?
We see it, Mark, thanks.
Okay. So, you know, we've been doing lots of TACEs, and I think as has been alluded to, we've become quite aggressive in TACing patients because we don't have the systemic therapies available. And I think it's worthwhile just to highlight that it's, we do so many, and patients are in and out of hospital very quickly the majority of the time. But I think, it's not always like that. And you have these patients that you remember forever. And this was a patient from 2019. So he was 72 years old, known with cirrhosis and hemochromatosis, which had been treated at another hospital with regular venous section. He had a good Child-Pugh score for most of the time that he was managed there for more than a decade. But he had no screening for hepatocellular carcinoma or for varices in the time that he was managed for the hemochromatosis. He noticed some weight loss in early 2019, and then he noticed a non-tender right upper quadrant mass, and that prompted a CT scan which showed the cirrhotic-looking liver with hypertrophy of the left side of the liver, atrophy of the right side of the liver, and a pedunculated mass arising from the bottom of the right side of the liver. And they referred him to palliative care and didn't really offer him any treatment. And he approached us for a second opinion. And when we saw him, which was about 3 months after the initial diagnosis, he was well-looking, 72-year-old, good performance status, apart from the hemochromatosis, no real comorbidities. On examination, there was nothing to find really except for this mass. He was HIV negative, no total core Hep B antibodies were negative, surface antigen negative, Hep C negative, normal UNE. Quite an elevated alpha-fetoprotein at 2,800, and a child. And you can see the liver functions and the full blood count. I've tabulated some of those results. His Child-Pugh score worked out then to A6 with a MALT score of 9. So I'm just going to show you. We did an MRI scan when he came to us. He'd already had the CT. And we did a gastroscopy that showed no real evidence of portal hypertension, although it did look like he had GAVE, and no ulcers or erosions in the stomach. So let's go back. This is the portal venous phase of a primavist MRI. Just going to go through it slowly. You can see there's a very big segment 2-3. If you look over there, that's the gallbladder. So you can see that there's quite an atrophic right side of the liver, and you can see the mass coming up and extending quite far inferiorly towards the right iliac fossa. There's no obvious invasion of certainly not of the main portal vein or the trunk of the right portal vein. So this is then the delayed coronal of the 15-minute phase of the primavist scan. And I think you get quite a nice picture of how the lesion is pedunculated and hanging off the bottom of the right lobe of the liver. A fairly easy liver resection. There was another small lesion in segment 2-3, and that was classified as LIRAD 3. This other lesion met the criteria for a LIRAD 5 lesion. So if you look at so the Barcelona Liver Clinic staging system, if you have a single lesion, it doesn't really matter on the size. As far as I understand it, you'd still fall into the early stage. But so we discussed it at an MDT meeting, and it was felt that the lesion was resectable. He had a good Child-Pugh score. We felt he would have enough liver if we resected the lesion. and we thought we could follow up the LIRAD3 lesion and we could microwave it if there was a concern. But because of mainly because of the elevated alpha fetoprotein, and that the lesion had actually got quite a lot bigger since the preceding CT scan, we decided to proceed with TACE to test the tumor biology after resection. So TACE we went down for the TACE. It was going to be performed via left radial puncture. Became very restless during the procedure, and the procedure was abandoned and it wasn't performed, and he was transferred back to general ward at Groote Hospital. And more than 6 hours later, he was noted to have dysphagia and a dense left hemiplegia. And what we hypothesized happened was that when they were accessing down to the hepatic artery via the arch of the aorta, that a little plaque got knocked off and caused the stroke. So he ended up having another CT scan a few months later. He was quite incapacitated by the stroke, and he ended up being managed palliatively. So this was quite a devastating complication, and you could argue whether we should have proceeded directly with resection or not. Thanks.
Thanks, Mark. Yeah, I think it's a good demonstration of we focus on the liver, think about the liver, what can go wrong there, but that any invasive procedure, regardless of what your treatment is, just the actual mechanics of the procedure can cause those kind of complications. Any other questions, comments for Mark? Okay, Brian.
Okay, Prof, let me just share. Okay, you can see my screen?
Yes, we see it. Thank you. And we hear you well.
Thanks. So the next case is a 46-year-old male we recently managed. He presented to us with a good performance status, social drinker. He had upper abdominal pain for 4 months and weight loss of about 70. His background history was notable for hypertension, which was well controlled, and diabetes mellitus. He had a normal examination other than wasting at the time of evaluation. And we had investigations that showed a normal full blood count and a U&E. His liver function tests showed ductal enzyme elevation as well as the transaminases. And he had an INR of 1.6 with a positive hepatitis B surface antigen, negative co-IgM with a viral load of 800,000. And he had a negative hep C. He had a negative HIV test, and his AFP was elevated at 120,000 with a CA99 of 376. So I'll just share this three phases with CT. So the first one is a arterial phase. It starts from the chest, but there are no pulmonary nodules, so I'll just go to the abdominal view. So you can begin to appreciate node liver surface with the hypertrophied caudate lobe and some ascites at the perisplenic area. You can also appreciate a hypervascular mass occupying majority of the right hemiliver. There's also peripancreatic bulky nodal lesions that are hypervascular. So the next image, sorry, is a portovenous phase. Let's go back. So on the portovenous phase, you can see the hypervascular lesion has begun to show peripheral washout. And you can see that the main portal vein is patent. The right-sided branches might be attenuated, but there's no obvious tumor thrombus. Sorry, I was showing the arterial phase. Let's go to the portovenous phase. Okay, so you can begin to see the washout, and it's a non-peripheral kind of washout. And then on the delayed phase, you can appreciate that significant, and maybe if you look closer, you might see the pseudocapsule. So this was a LIRAD 5 lesion. It's about 20 centimeters in size, occupying most of the right hemilever, with a patent main portal vein and its branches, and a cirrhotic liver. So our clinical assessment was one patient with chronic hepatitis B with relatively preserved liver function. That's a Child-Pugh came up to A6 with a MEL score of 12, and we graded his LIRAD 5 lesion and his clinical picture as Barcelona B. So at this point, maybe I'll ask the audience to think about what the role of biopsy would be, and we can also just have a look at the treatment options. So he falls in the intermediate group, and as Nassif had mentioned, we have quite a heterogeneous presentation in this intermediate stage, and our patient fell into the second criteria. So he did not really meet any extended liver transplant criteria, and he did have preserved portal flow and perhaps selective access, as we shall see in the next image. And he had well-defined nodules that were not, there was no obvious nodules on the left lobe, so it was not bilobar disease. So he underwent a TACE, and you can see that the tumor was hypervascular with good selective embolization. There were no obvious collaterals or parasitic vessels, and the was considered good. However, it presented back to us day 5 post-TACE with oliguria, metabolic acidosis, and rising creatinine, with a minimal response to fluid. And after an MDT discussion, we decided not to offer any invasive support, that is any intubation or renal replacement therapy. So he progressed to anuria, liver dysfunction with encephalopathy, worsening ascites and hyperbilirubinemia, and he demised. Thanks.
Thanks, Brian. Mark?
Thanks. Yeah, so we've been very anti-biopsy of HCCs, but I think we are trying to extend our criteria for transplantation. And if you think about this guy, he had one large lesion and he had an alpha-fetoprotein of 12,000. So the biopsy, Brian, if I'm not stand to be corrected, showed that it was moderately differentiated HCC. So the Toronto criteria for transplantation said that it looked at, well, basically, if you didn't have a poorly differentiated HCC, you were transplanted, your outcomes were the same as the patients transplanted within Milan criteria. So if he'd had a good response to TACE, his alpha-fetoprotein had come down, I think you could make a case for transplanting a patient like this. But unfortunately, this happened, and it's difficult for us to motivate to get a patient into ICU when they, under current criteria, they are for palliative intended treatment.
Yeah, I just wonder, Brian, the initial AFP was 800,000, is that right?
Yes, the initial AFP is 800,000.
No,
Sorry,
yeah.
120,000. That was the viral load.
Yeah.
Sorry, it was the viral load. Sorry. Yeah. So what was his AFP?
AFP was 120,000.
Yeah, that's also fairly high. Is there an upper limit? Is Sanju still on? Is there an upper limit when you think that TACE is probably not going to cut it?
Prof, there isn't actually. There isn't based on our data. Yeah.
One just wonders because we use it for a bad as a bad prognostic sign in all of the treatments, but seem to sort of forget it when it comes to TACE, and we use TACE as a tool to get it down. So I'm just wondering if there's a cutoff above which one shouldn't fiddle with it.
So
But again, Karan just posted in the group, he makes an interesting comment, is that the gamma GT is 1,148, which is above 800, right?
So, but Sanju, I think at this time the patient might have had hepatitis from the chronic Hep B. He had just started his anti-hepatitis B treatment. So I think the TACE happened a few months later, but that was the baseline that started on.
Yeah.
But sorry, we've had patients that we've resected with alpha fetoproteins in the thousands, and they come down to normal. So I think sometimes you can have a primary tumor that is just secreting a lot of alpha fetoprotein, and I think an important thing is the response to your treatment modality. I think if there's a massive drop, that supports you being aggressive with your other treatments. And that's why we do it, because TACE is generally the least invasive of the treatment options. But, not always. And I think we would TACE this guy just about every time if he came in. He had a good performance status. It was just that he had this very high alpha fetoprotein and hepatitis B.
Okay. I think we have to stop there. Thank you for the two interesting cases. And I think it's also good to show those patients that didn't go well. And I think we should still be very cautious when we even offer this treatment. Okay, Malini, it's your turn. Just about the complications and how we should follow these patients up.
Okay, I'm just going to share my screen. Okay, so I'm going to start off just by, okay, thank you. Just by mentioning a bit about the procedure of TACE itself. Because I think that is really the key to understanding the complications and the follow-up response of treatment. So if we look at TACE and the goals, it's really two things. The first being targeted tumor ischemia by embolization, and the second being the anti-neoplastic effects of the high-dose intraarterial chemotherapy. So with regards to the agent that is used, doxorubicin is probably the commonest, but there really is no consensus on which is the optimal chemotherapy drug or the dose of it. This agent is then dissolved in water or water-soluble contrast, which is mixed with ethiodized oil, which is the lapiodol. And this is then administered as a water and oil emulsion. And the reason for this is it just gives the molecule greater physical stability and allows for more sustained drug release of the doxorubicin. So in terms of a mechanism of action, as we know, the principles of TACE are based on the blood supply to the liver and of the HCC, which is largely by the hepatic artery, while the portal vein still remains for the rest of the liver. So the TACE is not to the main arteries itself, but instead into the distal tumor-feeding arteries and the arterioles, which are then embolized, resulting in ischemic necrosis and increased time of the chemotherapy agent inside the tumor itself. If we look at embolization and what is actually used for it, there are various particles that have been described, including PVA and gelatin sponges. So they have different sizes, and this has implications in terms of complications as well, which I'll talk about. But it is also important to look for any significant arteriovenous or arterioportal shunts prior to TACE or planning of it. And this is often found in the larger tumors because this can cause complications like pulmonary or systemic embolization of these particles. So if we look at how common complications are, the rate that described in the literature is really less than 4%, with the mortality rate being even low at less than 1%. So relatively low risk. If we look at the complications, I'd like to divide it up into vascular versus non-vascular. The vascular are all largely access related. So starting with at the puncture site itself, things like pseudoaneurysms and thrombosis. The next one being target vessel injury. The commonest is the hepatic artery. And this can range from anything from a spasm to a dissection of the artery. The non-target embolization is important. So this is partly because we know that the hepatic arteries are commonly have aberrancies. So there's often a replaced or an accessory right or left, and it's really important to identify these before planning your embolization as well. Otherwise, you get non-target embolization. And then I've already mentioned the pulmonary embolization. If we look at the non-vascular complications, I divide them up into HBV and non-HBV related. So if you look at the HBV side, there's the general things like ischemia or from infarction, infection, which results in a liver abscess or myeloma, rupture of the tumor and bleeding, and then strictures and ischemic cholangiopathy, which are more the later complications. And we'll go a bit into those. In terms of the non-HBV related, the commonest complication described is post-embolization syndrome. And this is described from around 20 to 90% of patients experience this. And it's really not a complication, but more an expected outcome after any patient has undergone embolotherapy. So what happens is there's ischemia to the tumor, you have release of the tumoral antigens into the systemic circulation and a widespread inflammatory response to this, resulting in generalized symptoms like fever, nausea, vomiting, pain, etc. And the treatment is really just supportive of this. And then renal failure is another important one, which I'll also talk about. So if we look at the first one, hepatic abscesses or myelomas, it starts generally in the center of the tumor where the necrosis and ischemia happens post-TACE. And then you can also get myelomas because the peribiliary plexus, which supplies your biliary tract, is exclusively derived from your hepatic artery. So if you're going to embolize your hepatic artery, the blood supply to your biliary tracts is cut off, and you're going to have loss of integrity, bile leaks, and myeloma formation. This is especially common in patients who've had previous biliary stents and patients who have biliary enteric anastomosis, obviously because of the reflux of contents up. Hepatic failure is another one, as we saw in Brian's patient that he presented. And this is described as a rise in the bilirubin, or worsening or new onset ascites, and or if they have hepatic encephalopathy within 2 weeks post the TACE procedure. And as you can see in this patient who had received TACE, has multiple hypervascular lesions. Post TACE, he has new onset ascites and some response to the TACE with the Lopidol taken up there. Renal failure, although quite a rare complication, is important and is also becomes more significant with repeated TACEs. They become at higher risk for it. So the causes of it is multifactorial, one being as a result of vascular depletion post the post-embolization syndrome. They also can get hepatorenal syndrome. There's contrast-induced nephropathies, which is largely volume and dose dependent. And then, as I mentioned, repeated TACE is definitely a risk factor for acute renal failure. Rupture or bleed is the other significant complication. And the pathogenesis is not completely understood, but it's largely thought to be due to increase in intratumoral pressure at the time of the TACE, and that can just be managed by embolization. Ischemic cholangiopathies or strictures, these are later complications. And like I said, it's because of the blood supply of the peribiliary plexus, which is derived from the hepatic artery. So interestingly, the non-cirrhotic patients more commonly develop this than the cirrhotic patients, because the patients with cirrhosis have generally already undergone hypertrophy of these plexuses prior, and so they still have some blood supply. Then there's a whole host of other systemic complications, from things like skin necrosis to spinal cord ischemia, pancreatitis, cholecystitis, and these are all largely as a result of embolization of the particles or of the Lopidol systemically into circulation with infarction in these various organs. So I'm going to move on to post-TACE evaluation and how we can assess treatment response. And before you actually decide on this, it's also important to consider, firstly, what types of therapy have they had? Has there been any interventions prior to the TACE? The number of times they've had the TACE, the timing of the imaging after therapy, because as Nassif mentioned, it's not that immediately there's any sort of response or shrinkage of the tumor on the scan. Then which imaging modality should we be using? And also to consider the cumulative effect of therapy on the underlying liver function. So really there are 3 goals and 3 questions you should ask yourself when reviewing the imaging. The first is to recognize residual or recurrent tumor that requires further treatment. The second is to identify complications from the TACE. And the third is to detect and characterize new lesions, because these patients generally have a background of cirrhosis and are at risk of developing new HCCs. So in terms of the imaging modality, the one that is most commonly used is a CT scan, and this should be done in 3 phases: an uncontrasted, an arterial, as well as a portovenous phase, which I'll talk a little bit about why. And it's only when this is equivocal do we then move to MRI. There are various systems or classification systems that look at evaluation of this response in imaging. As Nassif mentioned, the RESIST or the MRESIST, as well as the EASL guidelines and the WHO, and they all require measurements of the tumor size and volumes, etc. But there's also another system which was developed by the LIRADS, and they developed a LIRADS treatment response, which I think is quite simple and easy to use. So they have 3 response categories. One is non-viable tumor. So that if there's no lesional enhancement post-TACE, or if there's a treatment-specific expected enhancement. So that's if the lapidal is taken up and completely enhances the area that it was targeting. Then there's a viable category, which is essentially when the tumor looks like what you would expect HCC to look like. So that's no treatment response. And then there's an equivocal when it's not really meeting the criteria for either of these. If we look at the timing of the scan, the recommendations is generally that the initial scan should be 1 month post-TACE. At this scan, you don't expect to see any shrinkage in the size of the tumor, but it's really more a guide as to whether there is still non-viable tumor or viable tumor that requires further interventions. If we look at what features do you see on imaging, generally, it's easy to remember that the necrotic areas are going to retain the lapidal. Areas that enhance represents viable tissue. Often what is seen post-treatment is also a very thin peripheral pseudocapsule, and that's also normal, and it's a good response to treatment. And then I'll just show you an example of this. So if we look at this, these are scans done 3 separate times. So the first one is pre-TACE, and you can see there's hyper enhancement of the HCC. On the second one, this is an uncontrasted scan. So the reason you need an uncontrasted scan is the lapidal is taken up by the tumor. And if you look at it on a contrast enhanced scan and the tumor still is viable, you're going to have hypervascular enhancement of it anyways. And because of the lapidal, there's artifact, and you can't really tell the difference between the two. So an uncontrasted scan is really the only way to look at this. And you can see here there's incomplete lapidal uptake. So there's still viable tumor around that area. And then the last one is 4 months post a repeated TACE, and you can see here there's better uptake of it. Again, in this scan, you can see pre-TACE, there's a lesion, post-TACE, not much change, and then 4 months post-TACE, this patient has had still viable tumor, and you can see here there's a new lesion that is lighting up inside. So really, in terms of management of this, viable lesions require an MDT or a discussion about further treatment options. And if it's non-viable, follow-up imaging, generally in 3 months' time is the next step. So in conclusion, careful patient selection for TACE is important, and there are numerous complications with this. Signs, symptoms, and imaging are the key for diagnosis of these. And the assessment of the treatment response is quite complex and requires a thorough patient evaluation. Thank you.
Thanks very much, Melanie. Sorry, Ed had to just step out. Are there any questions or comments? Let's see if in the chat. Okay, it doesn't look like it. I think in the interest of time, as we've gone over the 1 hour, we're going to end the meeting there. So I'd just like to take the opportunity to thank all the speakers, to thank iEcho University of New Mexico and the iEcho India team, and just remind everyone that the recordings are available on the Gastro Foundation website. And thank you to the Gastro Foundation and the sponsors. And next week's talk will be on patient blood management. Thanks, everyone.